Hi, welcome to the NEET PG Core Revision series in pharmacology, where I'm going to discuss the important topics for the upcoming NEET PG examination. Today we're going to do drugs for heart failure. So, what are the drugs that are used or effective in acute heart failure? So, you know that in acute heart failure, the most important problem to solve is that there is a lot of edema, pulmonary edema. So, you have to decrease the fluid overload in the patient. So the best drugs for that are loop diuretic, which is furosemide, and we give it by the IV route. So what it does is it takes care of the acute pulmonary edema. Acute pulmonary edema, or we can say the preload also. Right? So these are the drug of choice for acute management of heart failure. First line therapy. Adverse effect because of any diuretic. So it most important here is decrease in the potassium levels, that is hypokalemia, and it can cause hypotension as well. Then you might have to add then nitroglycerin sodium nitroprusside IV. This is not sufficient alone, because similar way they decrease because it releases nitric oxide, and this causes decrease in the preload mainly, and also decrease in the afterload. But mainly it's the preload that is decreased. So again the similar line of action. So this can also lead to hypotension and headache. It's a vasodilator, so it leads to headache as well. Now remember, because it has a tendency to cause hypotension, so we take care if the BP is already, the systolic blood pressure, if it is less than 110, then we do not give. So avoid if the systolic blood pressure is less than 110 millimeters of mercury. Then what are the other drugs which can be used? We have hydralazine, which is an arteriolar dilator, therefore it causes decrease in the afterload. Then nisiritide, it is a BNP analog. Now because of this BNP analog, the most important thing is it increases the cyclic GMP levels, and this leads to vasodilatory effect as well as natriuresis. Again, this has to be given by IV route. So this is the role of the nisiritide. Then we have drugs. So this was one part of the problem that we solve in acute heart failure, that is the pulmonary edema, to decrease the fluid overload. Then we need drugs which have a positive inotropic action as well. So the drug of choice for this is dobutamine. So dobutamine you give it by the IV infusion rate or the infusion route here, that is continuous infusions, and what it does, it acts on the beta 1 receptors of the heart. Now remember, the classical thing about this dobutamine is, though it acts on the beta 1 receptors, it primarily has an effect on the force of contraction. So it mainly increases the force of contraction that is required, inotropic action. It has less effect on the heart rate. So it causes little increase in the heart rate. So because of this, there is little increase in the heart rate, the myocardial oxygen demand would also be less. But yes, if you give it in a higher dose, it can later on trigger tachycardia, which can predispose to arrhythmia. Alright, then if it doesn't work, then we add on another drug, which is milrinone or enoximone. So what is milrinone? So these drugs are called as inodilators. So what is the meaning of inodilator? That it has an inotropic effect plus it is a vasodilator. So there is positive inotropic effect and also it leads to vasodilatation. Why? Because it causes the phosphodiesterase 3 inhibition. Right? So this is milrinone enoximone, and the major problem because of this would be hypotension. Then we have levosimendan, pimobendan, which is available in Japan. So what is levosimendan? The role of levosimendan is that it is a calcium sensitizer, right? It is a calcium sensitizer. Therefore, it will go and increase the sensitivity of the contractile myofilaments to calcium. Okay, it's a calcium sensor. Wherever calcium is there, it's going to increase the force of contraction, right? Contraction increases. So it's a direct calcium sensitizer. Then we have a drug which is called as omecamtiv. Omecamtiv is what? It is going to cause myosin modulation, right? So myosin, remember, important for contraction. So it's causing myosin modulation. Then we have digoxin, which is not a primarily used drug, but for exam point of view, this drug is very, very important. So digoxin, it is going to act on the sodium potassium ATPase, and what it does, it increases the ultimately the calcium levels inside the cell, so increases the force of contraction, and therefore it will also increase the cardiac output. The important adverse effects here are mostly GIT related, which are more common. So we can find nausea, vomiting, and there are different types of arrhythmias which occur with it. So we are going to deal with digoxin in a little bit more detail later on. All right. Then very important, which are the drugs which decrease the mortality in heart failure patients? Very important to know. Right? So which are these drugs? The first group we have ACE inhibitors or ARBs. So remember, any drug which is going to decrease the aldosterone level will definitely decrease the mortality, because aldosterone is responsible for the ventricular remodeling of the heart, the left ventricular damage, the myometrium, the cells which become fetal type of cells, destruction of the cells, apoptosis of the healthy cells, and instead the cells which come and take its place are the fetal cells. You know, they are not very capable of taking up the action of the contractility. So therefore, the left ventricle becomes weak, it fails. That leads to death of the patient. So that is most important. The agent which is going to cause this remodeling is aldosterone. To an extent, even the sympathetic overstimulation causes it, but aldosterone is the most important factor which is causing ventricular remodeling. So any drug which is going to decrease the level of aldosterone will increase the or decrease the chances of mortality in the patient and prolong the survival rate. So ACE inhibitors, ARB, which are the AT1 antagonists, because they are going to ultimately decrease the level of aldosterone. So therefore, they decrease the ventricular remodeling. So they decrease the aldosterone levels. Therefore, they are going to have anti-remodeling effects. Then very important drug, if you can't give ACE inhibitors, ARBs, then we can also give ARNI. What is ARNI? It is an angiotensin receptor and neprilysin inhibitor. So your sacubitril and valsartan, or rather valsartan is an angiotensin receptor blocker and sacubitril is the neprilysin inhibitor. So what this drug is doing, it is ultimately going to cause vasodilatation, it is ultimately going to cause natriuresis. So again, angiotensin receptor blocker is a part of it. So this again is going to decrease the mortality chances in the patient, and this is used for chronic heart failure. Chronic heart failure. Its main adverse effect is, which we have to take care of, is angioedema. Angioedema. So we don't combine ARNI with ACE inhibitor, because again there will be increase in the risk of angioedema. Then very important group of drugs are beta blockers. Now not all beta blockers are approved in heart failure. There are 4 beta blockers important which are used, which have been proven to be effective in heart failure. So we have B, which stands for bisoprolol. Then we have carvedilol. Then we have metoprolol, and we have nebivolol. These are the 4 drugs which have been found to be effective. Out of them, the first 3, these are the first line. Nebivolol is not the first line drug, but first three are the first line drugs. So whenever we give beta blockers, take care that we do not give it in acute heart failure or acute decompensated heart failure. Always when the patient is in a compensated state, then we start with these drugs, because beta blockers are going to inhibit the beta 1 receptors, which is further going to aggravate the heart failure. So we started at a later stage when the patient is more stabilized. So we start with less dose, slow dose. So we use low dose of this, and we use it every 4 weeks. You can then increase the dose, but low dose is used, and in case of stable heart failure, not in acute decompensated failure. Now, what they do is they also decrease the heart rate. Important thing, they decrease the heart rate. And when they decrease the heart rate, they will decrease the myocardial energy consumption also. Right? That is very important. Also, they decrease the arrhythmias and sudden death because of arrhythmia. So, they decrease the chances of arrhythmias and therefore sudden death. That's very, very important for this. Then we have spironolactone, eplerenone, and finerenone. Again, they are directly going to inhibit aldosterone. SGLT2 inhibitors, what are they going to do is, they are like, these are your gliflozins. Initially, primarily, they were just the anti-diabetic drugs, but now they have been proven to be effective in heart failure, especially with low ejection fraction. So, if there is diabetes along with heart failure with low ejection fraction, these are the preferred drug or the drug of choice here. Because what they do, they inhibit the SGLT2 and they prevent the reabsorption of glucose as well as sodium. So, this factor is important for decreasing the fluid load, because with sodium water is also reabsorbed, so they decrease the fluid loss. They have been found to be very effective and decrease the mortality in the patients. Then hydralazine also has been found to be effective there, especially if you use with nitrates, isosorbate dinitrates. Then ivabradine. So ivabradine, as the name suggests, these are the drugs which cause bradycardia, pure bradycardia. Unlike beta blockers, which also inhibit the force of contraction and conduction, they only are going to inhibit the heart rate or decrease the heart rate. Therefore, they cause bradycardia only. Bradycardia only. So, when they decrease the heart rate, obviously they are going to decrease the myocardial oxygen demand. Okay, so that is important for them. So, they are approved for grade 2 to 4 heart failure. So, this drug, it is given if there is a contraindication, to beta blockers. And we can't give this drug if already the heart rate of the patient is low. So, contraindicated if heart rate is below 70 beats per minute. Already there is a low heart rate, you don't want to further aggravate the condition, so we do not give this. So, based on these, what we have done, so there was an MCQ in the previous years, which of the following drugs acts on both ACE and NEP, which is neural endopeptidase pathways indicated by the arrows. So, these two, ACE and neural endopeptidase, thereby influencing both vasoconstriction and natriuresis. Why? Because ACE is involved in the formation of angiotensin 2, which is going to cause vasoconstriction by acting on the receptor, and neural endopeptidase, it ultimately it is associated with the degradation of the BNP and ANP, which are diuretics and which are natriuretics and vasodilators. So, what you do, any drug which is going to inhibit this and this, what is it going to do? It is this pathway, no formation of angiotensin 2 here. So, therefore, it is going to cause or it is going to block the vasoconstriction, while the drug which inhibits the NEP is not going to cause degradation of these natriuretic peptide. So therefore, there will be increase in the vasodilatory effect and there will be natriuresis. So which drugs out of them does the same? Whether it is omapatrilat, sacubitril, losartan or nisiritide. So let's see omapatrilat. So omapatrilat is a drug which inhibits both ACE inhibitors and NEP. So this is the correct answer. Sacubitril, we just did in the ARNI, that is only a neprilysin inhibitor. So it acts only at this level. Losartan is only acting, it's an angiotensin receptor blocker. This is a neprilysin inhibitor. And nisiritide, it is a BNP. Right? So the correct answer is omapatrilat. Now remember, this drug is banned. Why was it banned? Because by both the pathways, it increases the chances of angioedema. So because of angioedema, that is the main issue with this. So therefore, this is not used, but it was asked in one of the exams. Now digoxin is a very, you can say, an exam favorite of most of the examiners. So one or two questions do come from this chapter and on digoxin. So digoxin, important things to know. So we know that digoxin is a drug used for heart failure. Yes. Half-life of digoxin is around 40 hours. Right? So if you have to give digoxin, so what, the steady state level is reached in 4 to 5 half-life. So about 200 hours. So many days are required for it to produce effect. Therefore, you have to give a loading dose of this drug whenever you give digitalization, that is called. Levels of digoxin. Again, this has a very narrow therapeutic index. So you have to be very careful while dosing the drug. So it should not go from it should stay between 0.5 to 1.4 nanograms per ml. As soon as you go more than 2 nanograms per ml, the toxicity starts showing. And in some patients, it can start even at low dose, even at 0.91. So most of the times, digoxin toxic does not really actually, it's not directly proportional to the concentration. You only have to check the signs and symptoms in the patient. It can occur even in the so-called therapeutic range. So you have to keep a check on the patient symptoms actually. Because levels are not a very clear or a true indicator whether there is toxicity or not. So most common cause of toxicity is in case the patient has some renal problems. So in renal insufficiency, because it is accumulation of the drug. So renal insufficiency. All right. So which is the earliest and the most common symptom? Those are your GIT symptoms, like there is nausea and there is vomiting and there is anorexia. Most common type of arrhythmia which is seen with this is ventricular bigeminy. Never seen with this drug is atrial flutter or Mobitz type 2 block. Mobitz type 2 block. It causes a classical vision defect which is called as the yellow vision or xanthopsia. The name is xanthopsia. So what are the treatment for the various adverse effect it causes? So if the ventricular arrhythmia occurs, it can be very, very fatal. The treatment for such kind of arrhythmia is lignocaine. So digoxin induced ventricular arrhythmia, the treatment or drug of choice is lignocaine. Lignocaine is a class 1 antiarrhythmic. Atrial arrhythmia, then what you do, your main concern is to prevent the conduction of the impulses from atrial to the ventricle. So we give something which will delay or which will prolong the AV conduction here. So here we can give beta blockers. Beta blockers. AV block has occurred. Then you need to give a drug which is going to reverse that AV block. So what you give antimuscarinic like atropine. So in bradycardia or in AV block, atropine is a drug of choice, and you can also do temporary pacemaking. Temporary pacemaker you have. So what happens when there is toxicity with digoxin? Is there an antidote available? Yes, there is an antidote available. That is called as digibind or DGFAB. What it does, it is going to form a complex with digoxin and therefore it is going to remove it from there. Triggers, what can trigger the digoxin toxicity? So if there is hypokalemia or there is hypomagnesemia. Obviously, there's hypomagnesemia, the opposite is calcium hypercalcemia. So all these three are going to trigger because it acts on the sodium potassium ATPase. That is the site here. So if there is hypokalemia, more of digoxin is going to act at this particular point because actually it's competing with potassium here. So if there is more, if there is less of potassium, then this will get more chance to bind. So remember, digoxin, it cuddles calcium, but it kicks potassium. So kicks potassium means it doesn't like. Kick starts with the K, so it kicks potassium. Potassium is K, and it cuddles calcium. Calcium with a C. Remember this important trick, right? So it doesn't like potassium, it kicks it off. So hypokalemia, actually, it can trigger digoxin toxicity. It cuddles calcium, it lies. So hypercalcemia, it is important for its effect or toxicity. That is what is there. All right. So with this, we come to the end of the important points of the drugs which are used in case of heart failure.